Okay. Yep. We like tricks. All right. So allergic rhinitis. This is, I'm going to keep going. If you need to pee, go for it. Um, for allergic rhinitis, this is inflammation. Most of the time you're thinking of this like runny nose, okay? So sneezing, rhinorrhea, pruritus, nasal congestion. Other people might have conjunctivitis, sinusitis, asthma. It could be triggering of that, okay? A lot of times this is seasonal. People just have seasonal allergies, okay? Um, can be triggered by airborne due to immunoglobulin on mast cells. So things that trigger this are histamine, leukotrienes, and prostaglandins. So the meds that we use to treat this are glucocorticoids. So we can give those intranasally to reduce inflammation, antihistamines to block that histamine response that can be given oral or intranasal. Excuse me, and then sympathomimetics, man, that was bad, can be given orally and intranasally as well. Okay, so an example of an intranasal glucocorticoid is mometasone. Fluticasone is another common intranasal glucocorticoid, and it helps to reduce that inflammation and control sneezing, itching, runny nose. Um, it is generally, if somebody has nasal congestion, this is going to be the first line treatment. Adverse effects, we've already said these: sore throat, nosebleed, headache, burning. The benefit of this is that this rarely causes systemic effects. Okay, so all those things that you might see from PO glucocorticoids, those could be avoided, or at least less severe. So they take it through the meter dose spray. Um, if they know that they're about to have seasonal issues, they can take it ahead of time to go ahead and like try to get ahead of it. Okay, so take it like a week before those symptoms onset. It would be optimal to clear your nasal passages before you administer this. So a lot of times, and I don't know why, this is, I guess I didn't read my drug book, or I didn't think about it, but I went to go give somebody their nose spray one day, and they're like, well, let me blow my nose first. I'm like, man, yeah, that'd be a good idea. You should probably do that. But you also could use like saline or something to try to clean their nose out before you administer this, just so it can optimally target it. So oral antihistamines. This is examples of these are cetirizine, loratadine, also used for allergic rhinitis. Um, these are usually most effective if they're taken prophylactically. So I'm sure people in this room take Claritin every single day. Like it's just my husband has to take Zyrtec every single day, and that's just his life. Um, they should be taken regularly to be most effective, whether they have symptoms or not. And then some mild adverse effects can be sedation. So I will tell y'all what those are in a minute, and that will make sense to you. Um, the intranasal are azolastine and alopatine. Man, that is not good. These are for people over 12 years old, and some side effects of those could be nosebleeds, those anticholinergic effects, the drying effects that we talked about, and unpleasant taste are potential side effects of those. Um, Intranasal cromolyn, and I have two different slides for these, so I will circle back. These work by reducing symptoms by suppressing histamine and inflammatory mediators of our mast cells. These are also used for prophylaxis. I want to give these before they're having symptoms, and usually it takes about 2 weeks for those to take effect. And they do generally have minimal adverse effects. The sympathomimetics, These are going to reduce congestion. They work by activating the alpha-1 adrenergic receptors on our nasal blood vessels. Some adverse effects of these would be rebound congestion. So like an example of this is Sudafed. So you take this and you're good to go, and then it goes into overdrive trying to compensate, and so you have the congestion. CNS stimulation, and then cardiovascular effects or stroke. So Sudafed, I think probably all of you have heard of this, know the side effects of that. That makes sense. We don't want people to use this nose spray more than 5 consecutive days. For the drops versus sprays, the topical agents generally act more quickly than orally, and usually more effective, but the oral agents do act longer, so you would need to take the topical more frequently. And then systemic effects usually come from oral, so to avoid those, we make sure we don't give people too high of doses or try to go the topical route. And then that rebound congestion I talked about is generally from using the topical. So these are examples of those: phenylephrine, ephedrine, Sudafed. And then these are examples of antihistamine, and then combo, the sympathomimetic.